There we go, and we are live. Welcome, everyone. Thank you so much for joining this evening. This is Ask Your Embryologist, and my name is Sandy Christiansen. I'm a clinical embryologist, a fertility coach, and advocate. This session tonight, brought to you by the European Fertility Society, is ICSI or not to ICSI, and should this be considered in every IVF cycle? A little bit of housekeeping, just a reminder that this session will be recorded, is being recorded and available on the Ask Your Embryologist website. So if you need to dash off early, you can access this recording at a later time. And also for best or easiest moderation for myself tonight, I would love it if you could pop your questions into the Q&A section, and we will get to as many questions as we can tonight. I'd love to introduce my expert guests with me tonight. We've got Natalia, who is the IVF director at IVF International in the UAE, and Victor at Institut Marquès in Spain. Start with Natalia. Would you mind telling us a little bit about yourself before we dive into questions?
Thanks for having me today evening. Thanks for inviting. That's the first thing. My name is Natalia Kondakova. I'm from Moscow, Russia, generally, but now I'm based in UAE, and I'm senior embryologist in IVF International Fertility Center, Dubai. I started my career like 15 years ago. Since then, I have been working as a clinical embryologist in Moscow, in Kazakhstan, and in UAE. So I'm happy to join, and hope my answer will be useful for you. Thank you.
Absolutely. Thank you so much, Natalia. And Victor, based in Barcelona, tell us a little bit about yourself.
Yeah, first of all, thank you for having me. As you said, my name is Victor. I was born in Barcelona, and I work as an embryologist for the past 9 years, mainly in Spain. Nowadays, I'm the lab director for the Institut Marquès group. We have a lab in Rome and a lab in Barcelona, and I'm managing both. And we're part of Future Life Group, which has a lot of clinics around Europe, so we have a lot of international access now. So patients in Barcelona are mainly international, so we have French, Italian, and even Australian patients, so we're used to dealing with a lot of cultures, a lot of languages. And yeah, just happy to be here and to discuss ICSI. I think it's an interesting topic.
Amazing. Thank you both so much. So yeah, we were talking a little bit about this backstage. So I started my career as an embryologist 16 years ago in Sweden. I'm now based in the UK. I've worked for public clinics, I've worked for private clinics, always under a bit of a strong regulatory body that tends to have a bit of opinions on conventional IVF versus ICSI. And backstage, we discussed a little bit around the fact that both of the clinics that you're working in do 100% ICSI, which is absolutely fascinating. So Victor, I might ask you first a little bit around the reasoning behind that for your clinic. Would you explain a little bit about when you came to that decision and why?
Yeah, in our clinic, we are doing 100% ICSI probably since 2018, I would say. And before we used to do maybe 10% IVF, and all of these cases were split cases. So we're doing half the eggs with ICSI, half the eggs with IVF. And that gave us a lot of information to consider and to see that for us, ICSI was giving better results, and not in fertilization, not in blastocyst rate, but lowest fertilization failures. And here we saw that the doctors in the consultation room was easier to explain that we were trying our best since the beginning. So we were doing ICSI since the first treatment. Like this, we were avoiding all these fertilization failures and having to repeat the treatment. So that was our reasoning behind doing 100% ICSI.
Of course, thank you. And yeah, so for those of you listening, fertilization failure is a very unfortunate event where you mix the eggs and the sperm in conventional IVF, and the next day when you go to do your fertilization check, you find out that none of the eggs have been fertilized. Generally speaking, laboratories will have KPIs or key performance indicators where we try to keep that number as low as possible, but I think some publications say that this is still roughly around 5%. if you have thousands of cycles going through your clinic every year, 5% is a lot. There are a lot of patients impacted by this, and that is sometimes what drives these decisions to moving towards, full ICSI, for example, to avoid that fertilization failure. And Natalia, you were talking a bit about your clinic as well, doing 100% ICSI. So you've got a bit more kind of treatments in that cycle of IVF. Do you want to explain a little bit about how your patients go through treatment where you are?
Yeah, sure. We are doing also 100% ICSI. We kind of brand new on the market in the UAE. We just opened 6 months ago. So for us, also the main reason is to avoid any bad experiences for our patients. So any fertilization failure or even low fertilization, we try to avoid. So for us, it's also the main reason why we perform 100% ICSI.
Of course. You also do a lot of genetic testing in PGTA, PGTM, PGT-SR. Would you mind explaining why ICSI is a requirement when you do those genetic testing methods?
Well, generally, ICSI is not a requirement nowadays because conventional IVF is also can be used when we perform testing, genetic testing. But generally, as I said, to increase the fertilization rates and to increase the number of viable embryos suitable for biopsy and to avoid any failures, we also use ICSI as a method of choice.
Yeah, of course. Well, thank you so much. So we do have a couple of questions that are coming in. So I'll go ahead and start asking the questions from the audience, and we can continue this discussion. And if you have any thoughts, those of you who are watching around IVF ICSI, any experiences you want to share, please continue to drop your questions in. So first question here from an audience member is that they've had multiple rounds of ICSI and around 40 eggs collected, but only one making it to the blastocyst stage and everything else tailing off after around day 3 of development. So their question is, should they be testing further, for example, with DNA fragmentation? They're constantly being told that it's maternal age, but wondering if it can be due to something else. Victor, if I start with you, what are your thoughts on embryo development kind of slowing down after day 3 of development?
Yeah, so usually when you have a case like this, that in day 3 the embryos stop developing, we think that it could be male factor. Obviously, we cannot guarantee that. But yeah, we tend to think that way because it's when the genetic material of the male activates, and then it gives rise to this stoppage of the cell division. But on the other hand, today we just saw a case in the clinic that we had a 31-year-old woman that was having exactly this issue, and they decided to split the eggs and do half with with sperm donor and half with the husband. And we saw that all the embryos did exactly the same, that they stopped development. So it's a proof that it's not only the male factor, but it can also be egg related. No, so yeah, we tend to think that way. And honestly, yeah, you could do another test to complement the spermiogram, and I think it's a good idea.
Yeah. Great, thank you so much for that. It's really difficult because, we do try to, we're sometimes like detectives as embryologists, where we try to figure out what exactly has happened along the way so that we can address it in the next cycle or address it before the next cycle. In regards to embryo quality, Natalia, is there something in your clinic that you see that you'd often recommend prior to going into another cycle of IVF if you've had this type of embryo development?
Well, generally, we try to evaluate the history of the patient always. Yeah. So if patient is has undergone for the cycle with us, we always see this information, and we see what we can change, which other options we can offer. So yeah, it's definitely good to see the DNA fragmentation, but also its lack of information here in this question. So such a cases need to be evaluated in general. So as Victor said, it's possible can be egg-related. Also, if it is PCOS, what was the maturation and how many actually got fertilized. How many reached day 3, and if only one reached blastocyst stage, which quality it was, has it been tested or no. So all of this can be evaluated as well to answer the question what it related with generally. So
of course, and yeah, that's a very good point. It's we discussed this last time as well. It's very rarely a very clear, yes or no question, and it is multifactorial, and there's a lot that goes into embryo development. But hopefully we have helped answer that a little bit for you. A next question that we have, someone has asked, are there any risks to the embryos and or future children by using ICSI? Victor, would you like to start with that one?
Okay, so there's a lot of studies, a lot of papers that speak about the safety of ICSI, the safety of IVF in general. And nowadays, there's not a difference. There's not a higher risk for using ICSI. The only thing that you could damage during ICSI is the egg itself, if it's not performed properly, or if the egg is a bit damaged or sensitive. So that could be an age-related factor or morphological factors that yes, a little low percentage of eggs could be damaged during ICSI. And that KPI is usually below 5% of the cases. And if your lab is performing well, you should have a low degeneration rate after ICSI. But that's the only thing that you could damage, not the future baby, not the future adult. That's not proven yet.
No, exactly. I think that's important to highlight. IVF and ICSI have been around now for decades, so we do have a lot of long-term data, and there's nothing to suggest that there is any danger to future offspring with ICSI. Thank you so much. Natalia, I've got a different question for you, and that is, we've got here, someone's asking, do we think that we're overusing ICSI as a default method? And could this have long-term an impact? What impact could this have on long-term outcomes or ethical considerations in reproductive medicine? And I think that's an interesting question. I will also, this might also tie in with something that we discussed a little bit when we were backstage before starting. For example, in the UK where I'm based, ICSI is an add-on, so it's an added expense. So this is why it's not added unless it's a medical necessity. In other places it isn't. So I'm not sure if that's the ethical consideration that is being highlighted here. But do you have any thoughts on this, Natalia? It's a very interesting question.
Yes, very interesting question. First of all, it needs to be mentioned, I think, that ICSI is a method of overcoming male factor of infertility. And there is many papers, research papers that state that some patients, some group of patients can benefit from the conventional IVF, actually. So in terms of overusing ICSI, it's used wider and wider all over the world. And actually, in my opinion, we need to be reconsidering it because it is already stated that it's not giving some couples a better chance to have a baby sooner. So it's not increasing our blastulation, it's not increasing the pregnancy rates. but definitely increasing and preventing us from the fertilization failure. So the success rates of fertilizations are quite high. As Victor said, if lab performs well, the generation rate should be less than 5% and the fertilization rates above 80. So this is quite what regarding ethical question. I'm not sure how it's in Spain or in London, if it's charged extra for ICSI or no. Generally in UAE, it's coming as a package. So in terms of money, patient pay for the package, and ICSI is already included in this package. Well, in terms of creating, as we say, artificial human using not very natural method, I think this is what we try to do in the lab is to mimic the nature. So we try to be as gentle as possible, and our methods also as natural as possible. So let us maybe discuss further on that, but I don't think there is any ethical issue regarding that as a scientist.
No, that's a very good point, and I agree. I think it was always interesting that there are some patients who have very, personal preferences on how conventional IVF feels a little bit more natural. And as a scientist, I don't mind. I feel like, IVF and both IVF and ICSI could be considered natural. And on the other end of the spectrum, some people might look at what we're doing and find it's the most unnatural thing in the world. So I guess it's all about perspective in that case. But thank you so much, Natalia. Right, so we've got a question around different types of ICSI now. So Victor, I might ask you this question. What do you think is better, ICSI, PICSI, or IMSI? And this is a 45-year-old who has male factor infertility and used Zymot and IMSI previously, but the new clinic only wants to use PICSI. So they want to understand the benefits of each. Would you mind first just explaining the differences between these three methods, and then kind of if you have any preference?
Okay. So in our clinic, we're very evidence-based. So PICSI, IMSI, and even Zymot have not been strongly proven to do an advantage. So I'm going to explain the difference. ICSI just regular ICSI, like we choose a sperm, we just put it inside the egg. And PICSI would be a more physiological solution, because we trying to find a sperm that has the capacity to fertilize, so the protein that's in the surface of the sperm, and through a process, we choose that sperm. And IMSI is just higher magnification that allows us to see it way closer and to find better, to choose better which sperm are we gonna choose. In our clinic, we're offering IMSI, but we don't see any benefits. We don't see, together with all the research purpose, we don't see any benefits of IMSI. And that being said, it's the same with Zymot, or any microfluidics. They're really, really trendy right now. A lot of clinics, including ourselves, are offering it, and we're doing a lot of data. We're collecting a lot of data to try to prove if we see any benefits or not. But for now, there's not strong evidence to support it. But every clinic has their own results, and that's what we're trying to do as a scientific community, to just aggregate all this data to come up with an answer for all of you. Just every clinic uses their preference. For me, my preference is just plain old ICSI and just doing it properly.
That's a great answer, thank you. So yeah, for those of you who don't know, Zymot is a form of, I guess it's much to your point, it's a type of semen preparation, but it's meant to help keep DNA fragmentation low if possible, or at least not increase it through the other processing methods that we have. So it is, to your point, a bit trendy. I think a lot of clinics have done their validations and show that, one, it can decrease time for the embryologist. Anything that does that means that we can focus our time more on patients. That can be a benefit in itself, but the clinical benefits might not yet be proven fully for some clinics yet. But that was excellent answer. Thank you. Natalia, do you use IMSI or PICSI at all in your clinic?
No, we just use classic ICSI. We are not offering IMSI and PICSI at all. But recently we switched to Zymo totally. So we stopped using centrifuge just for the very severe cases. So we are using Zymo for all our cases, for all patients. And what I'm still collecting data, but the euploidy rate, I already see from data that euploidy rate after starting using Zymo is increasing. So I definitely like it because it's really help us to focus mostly on advanced techniques, not on the like working in andrology much time. So and from my point of view, subjectively, of course, when doing ICSI morphology is much better after Zymo than after the conventional preparation, like a gradient. So we have opportunity to do DNA fragmentation test because we have CASA. So, but so far we didn't start this research like before and after Zymo. What is the DNA fragmentation level? But as far as I feel, if the DNA fragmentation is high, then even after Zymo it will be high. So. Yeah. Let us see. We will continue research and collecting data, but so far preliminary results are like that.
That's excellent. That'll be some very interesting research, Natalia. Thank you so much for sharing. So another question around the ICSI, they're asking, does this only look at motility or what is the benefit? So if I'm understanding this correctly, they're just asking around like what reasons would you be using ICSI for? And I think they're also ensuring that it's not based on DNA fragmentation because that's nothing we can see in with the magnification. Victor, would you mind helping me answer that question?
Yeah, so basically to choose the sperm, we choose the one that moves it's moves forward motility, and then it looks good. And so with sperm we are really strict, and only around 4% of sperm are normal. So that's to show that humans are not really great reproductors, like we're not really great at that. But yeah, it helps in cases of low of oligospermia, when we have low counts of sperm, in cases of teratospermia where the morphology is not as it should, where it's below this 4% I was mentioning, and then astenotospermia where the motility is not as it should be. And so in all these cases have been proven, in some of them benefit, that ICSI helps over IVF, and that's the point of this conversation, that if it's proven or not. And yeah.
No, that's perfect. Thank you so much. But yeah, it doesn't overcome anything like the DNA fragmentation, because that is unfortunately not something that we can visualize through the microscopes themselves. Perfect. Thank you. Keep these questions coming. Thank you so much, everyone, for being so engaging tonight. Natalia, question for you. If the embryo fertilizes, you've got a good quality embryo, why does implantation fail to occur? Part one of this question. What are your thoughts around that? Why do sometimes good embryos not implant?
Well, this is, if I would know the answer for this question, there are a lot of reasons for implantation failure. A lot of reasons, because it's multifactorial. Even the but generally, if PGTA is not performed, the first reason for implantation failure can be embryo aneuploidy. If it is tested embryo, then it is even more unclear why. But it also can be the uterus factors, the different microenvironment in the uterus. So generally, we don't know exactly what is going on if implantation failures. We just try to do our best to transfer the most viable in terms of morphology. If we are not performing PGTA, we are transferring the most beautiful, good-looking embryo. And if it is PGTA tested, then also it is morphology and also PGTA, normal euploid embryo. We have some nowadays we have also time-lapse technology to evaluate morphokinetics, which is specific timings of embryo development. So this can be also a tool to select the best one.
Yeah, that's lovely. Thank you so much. Yeah, so there are a lot of things that I think as embryologists we evaluate to help ensure that it is a good quality embryo or a genetically normal embryo plus the morphology, like Natalia said. The doctors will try to ensure that the uterine environment is as most optimal as possible for implantation, but there are still multiple factors that are unknown to us that can have an impact on this. So a second question in this one is, how can you grade the embryos? Victor, do you want to help us with that? We've touched a little bit about morphokinetics, so the timings of embryos, but grading embryos and embryo selection, what does that look like in your clinic?
So focusing on grading blastocyst now, which is a day 5, 6, or 7 embryo, the most common grading system is the Gardner score. There are several systems. I don't know if you, Natalia, you use it also the Gardner score, you use another one?
Yeah, we are using Gardner's.
Perfect. So that's the most common. In Spain, for example, we have our own, which is Elsevier score, but all of the scores look at the same. The amount of cells that we have in the embryo. So we divide the blastocyst, which you should imagine it as a 3D sphere. Now we divide it in 2 areas. The inner area that you can see like a ball inside, it's called the inner cell mass, and this is what will develop into the baby. And this, what we check is the amount of cells that this inner cell mass has. And when you see it by size, if it's bigger, it's higher grade, which is usually an A, and if it's a bit smaller or it's degenerated or it's not really like you cannot see it, then it's a C or D grade, depends on the grading score that you're using. And for the trophectoderm, that is the remainder of the cells that are enveloping the embryo, this we also just see how many cells there are. If we have a lot of cells, then it's an A. If we don't have a lot, then it might be a C or a D. And the last thing that we check is the expansion, how big this embryo is. If it's really, really big and it's hatching from the zona pellucida, then we can consider it a 5, depending on the score. It has a number or a letter, or depends on the score. But we check these 3 parameters: expansion, inner cell mass, and trophectoderm.
That's brilliant. Thank you so much, Victor. And you touched on something really important here too, is, well, we're talking about blastocysts, right? So these are embryos that are day 5 in development. There are potentially clinics out there and areas where they do embryo transfers earlier. But with your experience, having worked in multiple places, I'll ask you first, Natalia, what do you think the benefit is of transferring a day 5 embryo over a day 2 or a day 3, for example, if feasible in the laboratory?
The first benefit for transferring day 5 embryo is actually better embryo selection. So we just can see which embryo, if embryo developed blastocysts, that means it has potential. So if we do the embryo transfer early, we cannot predict which one, even if it's good, looking good, which one will form the blastocyst. Maybe still some clinics here in UAE, as far as per my knowledge, majority of clinics they perform a single euploid blastocyst transfer. Because generally also our aim is the live birth of one singleton. But I know that there are clinics that transfer early, and maybe still there are groups of patients that can benefit from transfer on day 3, which some patients that embryos are not developing, and many professionals still believe that the best incubator is uterus. So if it is a chance, it still can be a chance.
That's perfect. Thank you so much. That was a great answer. Next question here. This is a tough one. Since ICSI bypasses the natural selection process of sperm, how do you evaluate the risk of using a genetically abnormal sperm to fertilize an egg if there's no clear indication of male factor infertility? Tough one. Victor, would you mind helping me with that one?
So, unfortunately, using the microscope, we cannot see the genetic content. Otherwise, our lives would be much easier in the lab. That said, it's not been proven that ICSI either selects positively or negatively genetically abnormal sperm. So we're not choosing more abnormal sperm using ICSI that we would be during using IVF. Having said that, what we could do is to try to use the fish testing on the sperm sample to see if we have an abnormal proportion of genetically abnormal sperm cells. And that's a diagnostic technique that not a lot of clinics use. I think in the UK it's not that common. But in Spain it's really, really common. And we use it just to diagnose, to know if we should use PGT, if not, if we need to switch the sperm or not. So that's another diagnosis tool that we have.
Very, great point. And interesting. In terms of diagnostic tools, I think there are just, I guess, some limitations where, you have a lot of different tools available to you, met with the cost of what that is for the patient themselves, and when we are kind of exploring things that are proven, unproven, helpful, unhelpful, bottom line, we're all trying to work towards what is the best and quickest way to help achieve a pregnancy for our patients. And so sometimes things are not considered standard practice in some countries, and you try to do the best you can with what's available to you, shortest time possible, and also at, if possible, not the biggest expense to your patients. Thank you so much for that, Victor. Right, another question, keep them coming. This is a long one. I'm going to try to break this up into just a couple of different questions here. So we've got a couple here with a very high DNA fragmentation of 64%. They have been using ICSI, but also know that ICSI could sometimes damage fragile eggs, so they have a concern about the integrity of the egg quality as well. The question is, which insemination technique would you advise? I know that's difficult if you're both doing 100% ICSI, but they're asking, would you do only ICSI or maybe a mix of 50-50, so ICSI and conventional IVF? Natalia, do you have any thoughts on that? So high DNA fragmentation, fragile eggs, and insemination method.
To be evidence-based, I would not recommend any additional to the cycle, any add-ons. As I mean, in my current practice, we are not using it. But definitely, if there was a history of degeneration after ICSI, because some patients have more sensitive eggs, and there could be some reasons. I would do the split 50-50. I would try to do that. But there is no, as Victor said, there is no such method that can help us to decrease the level of DNA fragmentation during the procedure. So it maybe a specialist urologist, consultant urologist can help in terms of this to decrease, to change a lifestyle and or some medication to use to decrease the levels of DNA fragmentation before treatment.
And that's a good point too, something we haven't really spoken about either. You know, when we're talking about DNA fragmentation, there can be multiple different causes of that. With specialist urologists, it's not always that you have one at hand in fertility clinics. Do either of you have urologists that work and support you? Victor, if we start with you.
Yeah, we have a full-time urologist, so that's really helpful for our patients.
Yeah,
Okay.
sometimes it's
Natalia?
really helpful to remove varicocele if it is to do the surgery for varicocele if varicocele is big. So in these terms, consultant urologists can help.
Absolutely, and that's one of the known causes of high DNA fragmentation. So varicocele is an enlarged vein in the testicle. Both the location of it, the pressure that it causes, and the elevated temperature in the testicle can all have an impact on sperm production and the quality of that sperm. So in some cases, this can be corrected with a surgical treatment. It can help improve the quality of the sperm, which can then later on also help improve reproductive outcomes. So that's really handy if you have urologists to help support with this. Absolutely great questions that have come in. So don't have any more questions just yet. Happy to keep this conversation going. Those of you who are with us tonight, feel free to drop more questions in the Q&A. I have a separate question, I guess. So Victor, we talked a little bit about the sperm preparation techniques, etc. And how are you finding in your laboratory that, you know, kind of Zymote use? Is that something that you found beneficial for the workflows? You know, maybe Natalia mentioned that she's seen possibly an improvement in the morphology of the sperm in ICSI, but how do you feel that has had an impact just on embryology in general?
So we've been trying to implement Zymote since 2018, I think it was, and we did several studies to validate it. We had higher euploid rates, higher fertilization, higher blastocyst rates, higher everything, and we didn't see any difference. The only difference for us in our clinic was in the lab. No, we were faster and just more efficient with the sperm preparation. That's amazing, yes, but we also have to consider the costs. Here in Spain, at least in our clinic, if we use Zymote, we have to charge it to patients, and that's an extra cost. And if we don't see any benefit, that's not always what we want to do. So what we selected is a population of patients that they do benefit from Zymote, which is higher fragmentation, double-stranded and single-stranded fragmentation. In these cases, we saw an improvement, and it's only in these cases that, yes, we consider using Zymote. Otherwise, we use the classical version of sperm preparation, that's density gradients, that just using a centrifuge and do different density gradients to see which sperm is capable of arriving until the end of this density gradient. But yeah, only in a selected number of cases we use Zymote.
Okay, perfect. Thank you for clarifying that. And Natalia, you spoke a little bit about time lapse earlier. Is that something that you have in your clinic for all patients? Is that something that's a treatment add-on or offered to everyone? Is it included in a package? Can you speak a little bit about that?
Yes, we have time-lapse incubator available for all our patients. Currently, we are not that much busy, so I have one time-lapse incubator for 12 chambers. So far, all of my patients daily they fit in time-lapse. Uh, and but sometimes I split also in between benchtop incubator and time-lapse incubator. So it's quite useful for us because we can check fertilization, check embryo development remotely 24 hours, 7 days a week. So this really makes our life easy. And as for the patients, it doesn't cost anything for them. So we are just offering it as a part of the package. So and for the sperm preparation also Zymot is included. I know that the cost of the IVF cycle in UAE is much higher than in other countries. So we try to offer as much as possible, as much as we can. So far, we don't have any artificial intelligence linked to our incubator, but I hope soon we will have one. So this is something that we offer for all our patients.
That's great. Thank you. Yeah, I think that kind of the one leads into another in a little bit, because with time-lapse imaging, you've got a unique position where you can monitor your embryos throughout their entire development. You've got a camera essentially taking pictures of them every 5 to 10 minutes. You can time the exact cell divisions, and with that, you can learn a lot about the embryos, the embryo potential for implantation. And this is where those AI or artificial intelligence models come into play, because often they will try to predict those chances of implantation or help with the embryo selection. So this is all very interesting stuff that is in development. Right, we've got one more question here that has popped in as we've been chatting. Thank you guys so much. Right, any ideas on why ICSI isn't as commonly used in the UK compared with countries like Spain or the UAE, where it's often done as default even when there's no male factor issue? Oh, that's a question for me, isn't it? So, right. We in the UK, we have our regulatory body, which is the HFEA, that's the Human Fertilization and Embryology Authority. They have a code of practice, and it is often recommended by that code of practice that ICSI is something that should be offered as either a medical necessity for male factor issue, or in cases where there has been a failed fertilization with IVF. So essentially it is almost a requirement to be a medical indication. It is that way as well, I would say, the small caveat, because it comes at a cost. So you're looking at paying an additional £1,000 to about £1,200, maybe even more in some clinics these days, to have ICSI on top of your IVF cycle. And I think that is the majority of clinics. We very rarely see full package deals here that includes everything from your consultations, your scans, your egg collection, and even medication. You rarely see anything that encompasses everything with things like time lapse and ICSI. So it's a really good question, but I think there are definite cultural differences, there are different clinic differences, and of course regulatory bodies in different countries have different levels of what they actually can regulate, if that makes sense. So we all again, try to do our best, the best practice to ensure, the best chances of pregnancy for our patients within what we can do, what we can control. So I hope that answers your question. Right, I think something popped into the chat. Oh, thanks for explaining. So welcome. This has been wonderful. We've had some amazing questions. Happy to chat for a few more minutes, but we'll go ahead and round off shortly. Natalia, you're currently in the UAE. I know it's so late for you. We do
it's
so
fine.
appreciate.
No worries. It's very interesting discussion.
Good, excellent. So yeah, on that previous topic of, time-lapse AI models, I did want to just ask Victor what you're currently doing in your clinic as well, because time-lapse we know can have such a great, place to help ensure efficiency in the laboratory, which can then cascade into more time for, other really important things for the patients. Have you seen improvement in pregnancy rates? Do you use AI models? What can you tell me about time-lapse in your clinic?
Okay, so we've been using time-lapse since the early beginning. I think it was 2012, 2013. We culture, I would say, almost 99% of our patients in time-lapse. Unfortunately, in the clinic, still is an add-on. No, I would like to offer, that's just what Natalia was mentioning before, a round package that includes everything. But no, I mean, the economical reality is that it's an expensive machinery to have in the lab, so we have to offer it like this. We didn't see an increase in pregnancy rates overall when you're looking at thousands of patients. But when you see certain cases where you would miss fertilization in this egg, or you would miss this reverse cleavage, that's an abnormality in the embryo development that otherwise you would miss. In these cases, yes, for that patient, it made a difference. So maybe looking to thousands of cases, it doesn't increase by 5% pregnancy rates, but just that patient for them was really, really important. And that's, I think, what we try to convey in the consultation with the patients. Like, that's a powerful message to give, and that's why almost every patient decides to use time-lapse in our clinic. Also, for us, it's a transparency effort. We give access to the time-lapse imaging to patients live. So that's a lot of work for the whole clinic, because patients obviously do not understand what they're seeing. So there's a lot of questions asked. But that's a full transparency mode for us. Like, you can see the embryos. We're not going to lie to you what happened. You're going to see what happened. You can go to another clinic, and they're going to tell you that they're grading, this one is good, this one is not. So that's, I think, patients trust us because of that. That's a powerful message also.
Oh, that's excellent and so interesting. And yeah, you touched on something really important there too. There are events in embryo development that we would sometimes miss without time-lapse, which could result in multiple different scenarios. For example, those embryos that make reverse cleavages or have abnormal fertilizations, if we miss them and yet they form, beautiful, high quality scored graded embryos, we might choose them for freezing for future use. You might have an embryo in that cohort that doesn't have the potential to actually implant and generate a healthy pregnancy. So, sometimes it might not be increasing the chances of your pregnancy now, but it is ensuring that we're not reducing chances in the future. For example, we're not banking embryos that don't have that potential. We're not kind of providing a false hope for future use as well. So, excellent, very, very interesting points. We haven't had any more questions come in, so I think it might be a good time to just round things off. So grateful, Natalia and Victor, for you both being here this evening. It's been a great discussion. Really so pleased you could join us and support with your brilliant answers. So thank you so much. To everyone who has attended, thank you so much for your brilliant questions. Hope you feel like we've answered them well for you. Just want to call out that the 4th of June will be the next Ask Your Embryologist session, and we will be discussing PGTA. So there'll be lots on pre-implantation genetic testing for aneuploidy. So please feel free to sign up now, start asking your questions, and we look forward to answering them then. Natalia, Victor, again, thank you so much. I hope you have a lovely rest of your evening. And yeah, hope to meet you in person. Maybe we'll see each other at a conference in the summer.
Maybe. Yeah.
Yeah.
Everybody goes to Paris.
Yeah.
In Paris.
Let's catch up there.
Excellent. Have a wonderful evening, everyone. Take care.
Thank you for having us.
Thank you for inviting.
Thanks so much. Thank you.